for program delivery rather, for CATIE, and we welcome Michael to Halifax and for this presentation today. Thank you, Michael.
Thank you very much, Chris. The title of today's presentation is HIV Prevention in 2018. It's a very important time in HIV prevention. We know that there's no cure for HIV, but different new prevention technologies or tools have been developed, or the research has been done to prove that they are valid prevention tools. So a little bit about CATIE to begin with. We're Canada's resource for HIV and Hepatitis C Information. We were founded over 25 years ago, and it was an organization that was founded by and for people living with HIV at a time before the highly active antiretroviral therapies, or ART, were introduced, and it was people sharing information between themselves. At this time, we have a very extensive website where we have the latest news on HIV and Hepatitis C treatment. And this is in the language that people understand. We're a biomedical knowledge translation organization. So we do have a phone line, and the phone number is up here. People can phone from across Canada or write email inquiries on HIV and Hepatitis C. And every question we say is a good question. Our phone line's open Monday through Friday. In Eastern Time, that would be from 11 a.m. till 7 p.m. Monday through Thursday, that is. So the CATIE Ordering Center is also an important program that we have. And we have over 400 publications available in English and French that we will mail out to people online. So now on to our presentation. So today we'll be looking at new information about undetectable viral load and what that means for HIV prevention. Also we'll be looking at PrEP, pre-exposure prophylaxis, and we'll just review that the use of condoms, both internal and external, this is also another proven strategy for prevention. So undetectable viral load. Undetectable viral load, what does it mean and why does it matter? The viral load is something that people who are living with HIV are familiar with. It's a blood test that's done regularly for people who are HIV positive, and it measures the amount of HIV virus in the body. This particular test actually measures in a milliliter of blood, just a tiny amount of blood, a little bit more than a drop of blood, and it counts the copies of the virus. So the number of virus that's in that milliliter of blood. When we talk about undetectability, this is by the tests that we have right now, how much that it's not detectable. So this may be, some tests are 60 copies of the virus that they can detect, 40 copies, and I think more and more across Canada it's 20 copies of the virus. So under that, but with the technology that we have, it's seen as an undetectable viral load. Successful treatment with antiretroviral therapy, or ART, lowers the viral load and controls HIV replication. Probably you're already aware that there's no cure for HIV, but it can be controlled, and for somebody who is HIV positive, that the medications that are available now can suppress the virus so that HIV can be a chronic, manageable illness. Having and maintaining an undetectable viral load is good for the health of a person living with HIV. But now we'll look just a little bit at how it can help as a prevention tool. Taking antiretroviral therapy to maintain an undetectable viral load also helps helps prevent HIV. This means that if somebody has a low viral load or an undetectable viral load, then it lowers their risk of transmission. And this was a great, the two studies that we'll look at really proved that an undetectable viral load equals no transmission, or U equals U, undetectability equals untransmittable. So what we're saying is that HIV positive people on antiretroviral therapy who maintain an undetectable viral load do not transmit HIV to their sexual partners. Some important things to know. Certain things are required in order to rely on an undetectable viral load as an HIV prevention strategy. Undetectability will define what that is and what other factors need to be in place so that somebody's untransmittable. It's important to mention from the beginning that not everybody has access to care, to HIV care and treatment. So it's important just to state that in the beginning. Not everybody taking antiretroviral therapy is able to get to undetectable or maintain it. We are in a good position right now in terms of resistance to medications. That there seems to be something for pretty much everybody. So people can, with the medications, maintain or arrive at undetectability. People may need support, different groups of people may need support in order to be adherent to medications, meaning that to take their medications every day as it's supposed to be taken so that they can get to undetectability. HIV positive people, one thing that we also know, this movement of U equals U started about 2 years ago, and in the summer of 2016, two studies came to an end, or were brought to an end, that they proved that actually people didn't transmit HIV if they had a sustained undetectable viral load, were being regularly tested for other STIs, and were in care. So U equals U, this campaign that started 2 years ago now, it's a campaign promoted by a group of people living with HIV and advocates and researchers. It was started by a man in the United States, Bruce Richmond, who himself is HIV positive, who had several years earlier gone to his doctor following a broken condom with somebody who was HIV negative, and he was worried that he had transmitted HIV to his partner. His doctor had told him that no, that he didn't think that he would transmit HIV, and he asked why, and his doctor said, well, you don't, your viral load is under control, it's undetectable, and has been for some time. And Bruce Richmond had asked his doctor, well, why didn't you tell this to me before? Or why isn't this common knowledge? And he said, well, this information in the wrong hands might not be good. So in very much wanting information to get out, that he started the U equals U movement. You can read up here the whole statement, the U equals U consensus statement, which was adopted by the Prevention Action Group. You'll notice up here that it states that there's a negligible risk of sexual transmission of HIV. And people kind of grabbed onto negligible risk and were asking, what does negligible mean? Does that mean that there's a possibility? And this is important because people who are HIV positive don't want to transmit HIV. I think that's a general statement that they know what the risk is and they wouldn't want to give this to anybody else. So they needed some sort of a assurance that, that this wasn't going to happen. So understanding U equals U, and here are some Ontario Canadian advocates for U equals U, with Bruce Richmond, who's up there in the upper right-hand corner. And understanding a little bit about U equals U is important. In 2008, exactly 10 years ago, a group of doctors, Swiss doctors, did a longitudinal study, a study that was looking at health records across the country, their country, Switzerland, and looking at heterosexual serodiscordant relationships. And serodiscordant means where one partner may be HIV positive and the other one's HIV negative. So these were looking at health records of serodiscordant couples who were trying to conceive, so trying to have children, so that they stopped using condoms and were having sex. And we were looking in this statement at whether transmissions took place. And there were no transitions there. Transmissions, sorry. So this made for the statement that, in heterosexual couples, monogamous heterosexual couples, where this transmission wasn't taking place between serodiscordant couples. Just 1 second. So this statement came out, but because it wasn't a randomized controlled trial, it led other researchers to start studies. The first study was the HPTN-052. And the purpose of the study was to determine whether the use of antiretroviral therapy was able to reduce risk or eliminate risk of transmission. The study itself studied 1,763 serodiscordant couples, again, one HIV partner, one HIV negative partner, who had not started antiretroviral therapy. Half of them were to start antiretroviral therapy immediately, and half were to delay antiretroviral therapy. The preliminary results showed a 96% lower risk of HIV transmission among couples in the early treatment group. So, looking at the final results of HPTN-052, there were 8 HIV transmissions that occurred between partners while the HIV partner was on treatment. Of these, none of them occurred when the viral load was undetectable, however. So that showed that undetectability did have a strong or an important effect in reducing transmissions or reducing transmittability. We'll skip over that slide. Understanding the HIV transmissions in HPTN-052, there were 4 transmissions that occurred due to treatment failure or viral rebound. So a sustained viral load in this study, and this time the technology of undetectability was at 1,000 copies per milliliter, and that was after being on antiretroviral treatment for more than 6 months. So looking at treatment failure, how this would occur, of these 4 cases, it could have happened due to low adherence, so people not taking their medications as they were as prescribed, drug resistance, and this may have been drug resistance they had already, or it may have been acquired due to low adherence, or drug toxicity, that people just couldn't tolerate the drugs and weren't taking them. This study actually led to the start of another study that would be more inclusive and also look at sexual acts without condoms. In the HPTN 052, that this was sex with condoms. So the partner study, which is there, assesses the risk of HIV transmission when no condoms are used, and then where the HIV partner has an undetectable viral load. In this study, where people were recruited from around the world, there were 485 heterosexual and 282 same-sex serodiscordant, one partner HIV positive, one partner HIV negative, couples on antiretroviral therapy and not using condoms. This was an observational design. All of the couples were on antiretroviral therapy, and none of them were randomized to a control group. The preliminary results from this showed that there were no HIV infections when the viral load was undetectable, despite having 44,000 condomless sexual acts. So that's pretty good evidence that there was no transmission. All of the partners with an undetectable viral load, they had an undetectable viral load, and no condoms, PrEP or PEP, were used. PEP is post-exposure prophylaxis. It's important to see here, of the 434 male or the gay serodiscordant couples, there are almost 17,000 acts of condomless anal sex. 0 transmissions occurred with an undetectable viral load. So here, the take-home messages are, no HIV transmissions occurred when the viral load was undetectable, while the HIV positive partner was on ART and engaged in care. The strategy is effective regardless of whether condoms are used, but there is a risk of STIs. Evidence suggests STIs may not impact transmission in this context. HIV transmission can occur when on ART or antiretroviral therapy if viral load is detectable. Sex partners from outside the relationship account for HIV partners, HIV infections. And this was important that there were a small number of transmissions that did occur during the study, but looking at the strain of HIV that was in the infected partners, it wasn't from their partner. It was from outside the relationship that people were getting HIV. So a little bit about what this means. And it's meant that this knowledge has meant that people who are HIV positive, who have a suppressed or undetectable viral load, can't and do not transmit HIV. And this has been a real change in the world of HIV. For people who are HIV positive, it means a little of the self-stigmatization that may happen, that the belief that they're vectors of disease, or that they're transmitting infection and can hurt their partners, isn't necessarily true. If they stick by these rules, definitely not true, that of maintaining, attaining and maintaining an undetectable viral load over a period of time, being involved in healthcare, and not having STIs. And it's all together, it's a package of undetectability. A little bit about how we should talk about U equals U. And this is important for service providers. The key points that are necessary to communicate to clients are that a prevention strategy is dependent on viral load staying undetectable over time. that high adherence to medication is necessary. Just because somebody is undetectable 1 year or 6 months, that they need to be observant or adherent to therapy, but also also to get tested at least every 3 to 6 months. And the viral load should be undetectable before this strategy is seen as reliable for 6 months. It's important for people with any issues around this to discuss them with their healthcare providers. Okay, so supporting clients who are HIV positive or negative, who are involved in, who are looking at U=U. It's important to support treatment uptake, to be on treatment, and also to be adherent to treatment. And adherence to treatment generally means to take medications the way they're supposed to be taken. The decision to go on antiretroviral therapy is a personal choice, and I think that the support and education that service providers can provide is really important in making these decisions. Once again, it's important to remember that there is inequitable access to care and treatment across the country, and not everybody can maintain an undetectable viral load. And this is important, we can't stigmatize people who aren't able to reach an undetectable viral load. Adherence is about keeping HIV positive people healthy and is affected, and this is the important first reason for taking treatment, the health and wellness of people who are HIV positive. But people also need that accurate, comprehensive information about U=U. Few things to remember. U=U isn't new information. Telling people about it is new. It calls for a big shift in attitudes, and that takes time. And in Canada, where there is criminalization of HIV non-disclosure, the law is a little bit out of step with the scientific knowledge. So that's U=U, I would say, the major thing of 2017, and seeing how that plays out across the country is really important. A little bit now about pre-exposure prophylaxis, and I'll refer to it by its acronym of PrEP from now on. So PrEP is about the antiretroviral drugs antiretroviral drugs taken by HIV negative people to protect themselves from exposure. So taking medications, in this case Truvada, which is tenofovir and trazitidine or FTC, taking it, HIV negative people, taking it on a regular basis to prevent getting HIV. And this involves, for that person, regular visits to a clinical provider to test for HIV and also STIs, to look at side effects and toxicities to the medications, and to provide adherence support. It's important, there's a lot of talk about PrEP, sometimes a stigmatization of people who take it, and looking at them as people who may be just looking for something so that they can have as much sex as they want. I think we have to remember that people take PrEP not for their whole life, it may be for a period in their life where they're getting involved in risky activities. And PrEP itself, it may be seen as expensive, but it's much less expensive than a lifetime of HIV treatment. So PrEP, what is it? And it was approved in Canada by Health Canada in February 2016. And this is, it had been approved for the treatment of HIV. It was approved as a prophylaxis. So as a pre-exposure prophylaxis. Before that, doctors had been prescribing it, but had been prescribing it off-label. Just in December 2017, the guidelines were released for the use of PrEP. And it was very recommended for people who were at high risk of HIV transmission. When used correctly and consistently, it's rare that HIV transmission would occur on PrEP. In Canada at this time, the access to PrEP has been approved by Health Canada, but people who have private health insurance can have it covered. But it does cost, $7,000, $8,000 a year in different parts of the country. So it's something that the cost is prohibitive for people taking the treatment if they don't have private insurance. That was up until a year ago. Quebec, as part of their drug program, had approved the PrEP 2 years ago. Ontario has approved, as part of their Trillium drug plan, a year ago PrEP. BC also has approved PrEP use. But it's scattered across the country. It's pretty scattered in about which provinces will cover it. In Nova Scotia at this time, it's not covered by a government catastrophic drug plan, although private insurance is paying a major portion of it. So there is a lack of accessibility across the country. So how does it work? Research has found that PrEP is highly effective when taken by heterosexual men and women. We noticed that for women, for the full potency and penetration into the genital tract for full protection may take a little bit longer than for men. Gay and bisexual men and other men who have sex can use it, and this is the population now that's the most highly educated around PrEP use. And they have that knowledge, and also the treating doctors in gay communities in large cities are aware of PrEP more than in other areas, so it may be easier to get PrEP in the big cities. It may have some effect, oral PrEP, in drug-using communities, so people who inject drugs. There needs to be more study done there, however, it's not definitive. Adherence is very important. Adherence, taking medications the way they're supposed to be taken, when they're supposed to be taken, is important to protect from HIV infection. So how well does it work? Adherence shows that consistent use of PrEP can reduce the risk of HIV infection by 85 to 92% for sexual transmission, and up to 84% for people who use drugs. It's effective for both men and women when used consistently and correctly. However, drug levels are lower and accumulate more slowly in the vagina than in the rectum. It may be more important to take pills every day and not miss any doses for women and trans men if they're having vaginal or frontal sex. In Quebec, there's been a study that's a study in Quebec and France that's looking at intermittent PrEP use amongst gay men in those areas. And in this study, and it's called the EPA-GAY study, it's a sex-driven study. The medications aren't taken every day, but they're taken 2 tablets 2 to 24 hours before having sex, and 1 tablet every day after while sexual activity is taking place, and 2 tablets after the last sexual intercourse. In EPA-GAY, 3 people on PrEP acquired HIV, but all 3 were not adherent to PrEP. I mean, you still have to take the pills 2 hours before a first sexual activity, 2 to 24 hours before a sexual activity. This PrEP on demand, before and after effect, has been highly effective in gay, bisexual, and men who have sex with men. It's not expected to work for women or trans men, and this is the reason that perhaps PrEP, the medication, is slower to penetrate women's sexual genital tract. The Canadian guidelines recommend on-demand PrEP, this taking of PrEP 2 to 24 hours before a sexual activity and continuing to take it while having sexual activity and with 2 pills afterwards. It's recommended for gay, bi, and men who have sex with men only. And the idea here is that there needs to be more study in other populations, in women and trans men, but with the knowledge that we have around transmission, that it may not work. So the key messages for people on PrEP. For clients taking PrEP or considering taking PrEP, you should know that PrEP does require consistent and correct use of these HIV medications. It should only be used by people who are HIV negative. It should be assessed with the support of a healthcare provider, and it requires that people be tested for hepatitis B, HIV, and other STIs and have kidney function tested before starting PrEP. It does require regular visits to a healthcare provider, regular exams for HIV and overall testing for STIs, and also to monitoring of the potential side effects of these HIV medications, and also to some counseling and support around adherence. So how does PrEP work in the real world? Ongoing studies in the real world continue to show that when PrEP is taken consistently and correctly, it's rare for HIV to be transmitted. However, evidence shows PrEP is not 100% effective. 3 cases of transmission have occurred while people have been on PrEP. So how safe is it? There may be side effects, and this may include diarrhea, nausea, headaches, fatigue, and dizziness in 1 to 10% of people. And this may be during just the first starting treatment, so the side effects may go away after time. Some participants experienced small decreases in kidney, liver, and bone health. Drug resistance was generally rare in the studies, and it's important to remember that although HIV transmission may be stopped, it doesn't protect people from other STIs, so people who are on PrEP are asked to have regular STI testing or monitoring. It is important to mention, and this is something when PrEP first came out, that there was this thought that people would be having more unprotected sex, and it would increase the rates of other STIs. And we know that people who are at high risk for HIV already have high rates of STIs, although quarterly follow-up for STIs means that they're detected and treated promptly. There was this myth that PrEP would lead to more risky behaviors, and studies have consistently found no association between PrEP use and changes in sexual risk behavior. So a little bit, we talk about PrEP and its availability in the large cities and the large provinces now, but it's not generally accessible outside the large cities. You need to find a healthcare provider who will prescribe it, and you need to have a way of covering it. You need to either have private insurance, or you need to be in a province where it's covered. So here on this particular slide, you see that this is one of those miracle drugs. If you can afford it, it's a miracle. And although it's getting easier in parts of Canada, it's still not universal. So increasing access, so how do you do this? We can raise awareness about PrEP as a highly effective strategy. We can support people who decide whether PrEP is right for them. And this is an educational role that is for healthcare providers and also service providers. And support for service providers to support their clients in their discussions with their healthcare providers about their sexual behavior. It's important to work with people who know about PrEP, and there will be a national education campaign for doctors to be able to get that information to be able to prescribe PrEP. It's important for service providers to be able to support their members or their clients to be able to find out how they can pay for PrEP. So the message here is to advocate for greater access in their region. So that's the information on PrEP. I just thought it's important to add here, condoms are still a highly effective strategy to avoid HIV transmission. If condoms are used correctly, they're 100% accurate from what we know. So condoms, both internal and external, they're barriers. The external condom is a condom that fits over the penis. The internal condom is a condom that may be placed within the female genital tract or the rectum to stop HIV transmission. So how well do condoms work for HIV prevention? If used correctly, condoms do not break, slip, or leak, and there is no exposure to HIV that takes place. Failure rates range from 0.4% to 3.4% if there's breakage, slippage to up to 1%, and leakage of 0.4% to 6.5%. Incorrect condom use is important. It's important to use condoms that before their expiry date, to make sure they're not sitting in the back of your wallet for months and with possible perforations that can take place or breakages. But they can reduce transmission. So a little bit about the use of them. And here we have observational studies. There have been no randomized control trials of the use of condoms, and I think we know why. But meta-analyses have estimated that there's an up to 94% risk reduction. And observational studies of condoms have some limitations here, that it's self-reported on condom use. They don't evaluate correct use, and the lack of randomization. As summary, that condoms are a highly effective strategy for reducing the risk of HIV transmission. For many people, a high level of effectiveness may be difficult to achieve. However, service providers can play an important role to improve uptake and consistent use. So we'll look at other modes of transmission now. We know that HIV can be transmitted through the sharing of injection equipment. The major thing here to reduce transmission is not to share syringes. But available research suggests that the risk of transmitting HIV is also considerably reduced for people who inject drugs who are on treatment and maintain an undetectable viral load. We need a lot more research there. Also, perinatal and transmission, what was called vertical transmission. We know that antiretroviral therapy taken by HIV-positive people during and post-pregnancy and by their infants post-delivery have significantly reduced the risk of perinatal HIV transmission. Looking at breast milk, and this is something that is being studied but needs more study, at different points in the lactation cycle, people may be more or less transmissible. Not people, but breast milk would be more or less transmissible. And there needs to be some research that's done there. The available evidence doesn't confirm that the risk is negligible with an undetectable viral load. So that's pretty much my presentation. At the front of at the beginning of the presentation, there's my email address, and I'd be happy to answer any questions that you have them. Thank you.
Does anyone have any questions? Perhaps I could add a little bit of Nova Scotia-specific context, especially to the information around PrEP, pre-exposure prophylaxis. As Michael mentioned, access across the country is highly variable, and access even within jurisdictions where it might be at the most accessible is still highly variable. It's an expensive medication. Truvada, which was the drug originally done, all the research was done on and then approved, is the branded version. And that costs about $1,000 a month to take on a daily basis, which is what's recommended as a baseline PrEP protocol. The patent on Truvada, however, expired a year ago. And since then, Health Canada has approved 4 generic equivalents, which are now on the market. And depending on where you are in the country, those generic equivalents range between $250 a month to about $500 a month. The information, however, on this is shifting perpetually. And because of that, the AIDS Coalition of Nova Scotia has a PrEP information page on our website where we can update the details as to what is the current situation, what is the cost, what's the best cost-effective ways to access PrEP if you have a doctor who is willing to prescribe and you are in a high-risk category, et cetera, et cetera. So we're trying to provide as much information as possible to the general public, but also to healthcare providers, many of whom, for whom this is also still very, very new information, even if it's perhaps they haven't even heard of it at all at this point. The protocol only came out for Canada in November past. That's also available on our website. So there's a lot of information that is available. The matter is, the challenge is, of course, to get it to people who want it and need it and who would most benefit from it. So if anybody has questions about that, please check our website. And if our website doesn't answer the questions, feel free to contact Michael or myself locally. I'm the Gay Men's Health Coordinator with the AIDS Coalition, and I try to keep on top of this subject from a local perspective in terms of the research, the access issues, the cost issues, et cetera, et cetera. Also, within Nova Scotia, there is a group called the Nova Scotia PrEP Working Group, which is an ad hoc collection of community advocates and people who are involved in healthcare in one capacity or another to work at addressing and overcoming the barriers to accessing PrEP. And one of those barriers is education, both public education and healthcare provider education, and so we're working in various ways around that. The cost is of course a barrier as well, so we have some colleagues who are having discussions with the Provincial Department of Health about whether or not this can be added at some point to the provincial formulary, which is the first step for perhaps then being covered by the province to whatever communities or priority populations they determine and with whatever mechanisms. And again, that approach in terms of providing government coverage is different with each of the 3 provinces we currently have it available. So it's also a matter of which model will they take up? Will they provide it to all the high-risk populations, only to very certain people under very certain circumstances, et cetera, et cetera. So again, so some of my colleagues are having those conversations with government officials and have been now actually for over a year. Those conversations are ongoing, and the fact that we're having this conversation, however, we see as a good sign. So, any questions about any of that? Once? Twice? Anything else you'd like to add, Michael?
No, very good, thank you. So things are happening here.
things are happening here. We're a little behind the big centers, but that's not unusual. But we are making slow visiting progress.
Very good. Thank you.
Thank you, Michael.
So on behalf of Halifax Public Libraries, I'd like to thank you, Michael and Chris, for being here today. And thank you, the audience,